Hello, very good evening to all of you. So my name is Saurav. I'm the head of marketing from Samarth Oncology. As every time today also we are here in the same platform, Osmosis, to exchange the experience from the different faculty members available today with us during their busy schedules. Uh, Today in the Osmosis, we are going to talk about the three real-time
सुबह एक शाम को आना
experience on a masterclass on the diagnostic to decisions. Today is 11th of August, and we are going to
दिन
discuss
में एक
these
बार
three case studies on neuroendocrine tumor, prostate cancer, and the BRCA mutated cases of ovarian cancer. So, with that, I welcome all of you on behalf of Samarth Oncology and the organizer Mice Ideas, all our faculty members, where we have respected moderators, Dr. Chandrakant sir. Uh, he is a consultant medical oncologist from NH Hospital, Kolkata. Dr. Amarendra Amar sir, he is a consultant medical oncologist from Medanta, Patna. Dr. Prasanta Kumar Parida sir, who is consultant medical oncologist from SCG Cuttack. With this, I would like to hand over the for a few points and the content to discuss. Miss Anjana, who is our medical team, is from our medical team to take over these sessions way forward. Thank you.
Thank you so much, Saurav. Once again, good evening, everyone. I would like to welcome all the speakers, panelists, delegates, and Team Samarth. I am Anjana Yadav from the medical team of Samarth Life Sciences. On behalf of the organization, I am delighted to warmly welcome you all to today's webinar, which we proudly present under our flagship scientific initiative, OSMOSIS. So, what is Osmosis? Osmosis is an academic platform conceptualized and driven by our oncology division on Quest with the objective of fostering meaningful scientific exchange in the field of oncology. We initiated this program approximately 3 years ago with a vision to create a credible, knowledge driven forum where experts could come together to share their insights, discuss the evolving evidences, and deliberate on the real world clinical challenges. Over these 3 years, Osmosis has steadily evolved into a highly valued and trusted platform for our oncologists. It has gained recognition for facilitating rich academic discussions, promoting continuous learning, and enabling the dissemination of the latest advancements in the oncology practice. The consistent participation and engagement from the esteemed oncologists across the country stand as a testament to its growing relevance and impact. Through this initiative, Samath remains committed to advancing oncology care by fostering platform but a Osmosis is not just a scientific platform, but a powerful metaphor for the dissemination of knowledge. The focal point of today's discussion will be on osmosis, on the three real world case scenarios, a masterclass on diagnosis to decision. We are fortunate here to have our esteemed moderators for today's session. So before going ahead, I would like to one second. Before we start, let me give you a brief about our company profile, Samarth Life Sciences. So, Samarth Life Sciences is an innovative life science company that researches, develops, manufactures, and markets a broad range of life saving critical care products and other drugs. With our vision to emerge as an innovative premier healthcare company, we are committed to deliver healthcare products with the highest level of operational excellence. Since its inception in the year 1963 by Mr. Gunwant Lal Shah, Samarth Life Sciences has been a prominent player in the pharmaceutical industry. Samarth Life Sciences operates through 13 therapeutic specialty divisions, each focusing on specific areas of healthcare to provide targeted solution and expertise across a broad spectrum of medical conditions. OnQuest is one of the division that caters to the oncology specialty. Samarth Life Sciences is a WHO GMP and ISO 9001 certified that ensures the highest standards of quality and manufacturing practices. We export over 250 products in over 70 countries, demonstrating our global presence and commitment to serve the diverse market. We are also proud to share that Samarth Life Sciences has received significant accolades and recognition reflecting its excellence and influence in the healthcare sector. With this short brief about us, we would like to initiate the scientific program. So, as Saurav has already said, that today there will be three case presentations on three different topics. So, let us start with the first case presentation. So, the first case presentation would be on NET, the evolving science and the practice. The moderator for this session would be Dr. Chandrakant MV. He is a consultant medical oncologist at NH Hospital, Kolkata. And the panelist for this case presentation would be next, Khushi. Okay, the previous one. Okay, the panelists for this case presentation would be Dr. Shri Gopal Mohanty sir. He is a consultant medical oncologist HCG Cuttack. Dr. Avinash Pandey sir, consultant medical oncologist Adhya Cancer Institute Patna. Dr. Rajiv Bhattacharji sir, he is a consultant medical oncologist Peerless Hospital Kolkata. Dr. Thamizoli Selvaraju. He is a consultant radiation oncologist at ACCF Bharpeta. So, with this, I would like to hand over the session to Dr. Chandrakant sir. Dr. Chandrakant sir. Yes, sir.
So, will you share your slide or do you want us to share your slides?
Just sharing.
You are sharing.
I'm just noting the panelists' names. Sorry.
It's okay, sir.
Okay, so thank you, uh, Anjana, for that kind introduction, and I would thank for this wonderful opportunity to discuss on the cases on neuroendocrine tumor. You know, it's one of the rare events where a malignancy like NET is discussed. We rarely discuss this, so it's an opportunity that we put our thoughts in handling these diseases. Okay, I think I like this slide. The goal is to understand our practice. It's not a Bonvita quiz contest, right? So we are not quizzing and finding out, okay, tell me what is the hazard ratio. Okay, tell me which is the drug. So that is not we are here for. We are here to understand what's our practice and how do we use. And I like the case. So the case is actually the way I usually treat. So let me just take you through the case. 58-year-old lady had some abdominal symptoms, acidity, weight loss, abdominal ultrasound showed bilobar liver salts. A PET CT FDG, okay, showed a mild, I mean, FDG avid mid-body stomach, perigastric and gastrohepatic nodes, abdominopelvic peritoneal deposits, and bilobar multiple, right? Doesn't look resectable. Okay. So stomach, peritoneum, lymph nodes, and liver. So tumor markers, CA is okay, CA19.9 normal, CA125 is mildly high because of peritoneum being there. So biopsy of the liver surface deposit cellular tumor with thickened trabeculae and ribbon-like pattern. I think this is the morphology that is visible. I don't understand this. The pathologists understand this. Gastric biopsy is a well-differentiated NET grade 2. Okay, so it is probably similar to a liver biopsy thing. Synaptophysin and chromogranin are positive. So it's a clear-cut NET. It's a Ki67 of 15%. So it's a grade 2 neuroendocrine tumor, right? So because it was neuroendocrine, they did a DOTA knock because you'll understand the disease sites better and also the somatostatin uptake, So liver lesions are there, peritoneal deposits, omental deposits, okay. So compared to FDG PET, stomach lesion, lymph node, peritoneal and omental deposits show more FDG uptake. Perihepatic deposits show evidence of internal necrosis now. Okay. So what I understand is there are some lesions which are very strongly DOTA avid. There are some lesions which are FDG avid. So it's not a homogeneous disease. Chromogranin is 67. Okay. So grade 1 and 2 NETs, right? We treat it as a lower grade 1, right? And this is somatostatin avid, and some is also FDG avid, right? Let me start with Dr. Shrigopal. Dr. Shrigopal, all the options are fine. I mean, it's confusing. But
Sir, good evening.
hi. So, Dr. Shrigopal, the question is, what factors in this scenario which are concerning where you cannot use a SSA alone? I mean, SSA alone comfortable, but some factors, no, like something like FDG, burden or something. So there I am little, you feel
Yes, sir.
that probably SSA may not be, sufficient. What do you think are those factors?
Agreed, sir. First of all, looking at the clinical presentation, having such a gastric lesion with nodal disease, heavy omental disease, liver surface deposits, liver parenchymal deposits. So it's a very high volume disease with biopsy proven neuroendocrine tumor grade 2. Still, there is some discordance between FDG and Dotanoc PET CT. Although there is definitely a high Dotanoc uptake also. So it's a somatostatin avid lesion. So upfront, considering the high volume disease, I will be looking for adding some sort of either PRRT plus SSA would be my first choice if it is available. Otherwise, with SSA, I will be adding some sort of Captem regimen or mTOR regimen.
Right. So I think I see we are not looking into one single answer because it depends on multiple factors, like
Yes.
as Dr. Shrigopal said, affordability, accessibility, whether it's there or not, whether a patient can tolerate KFM, all these matter. But one thing I think Dr. Shrigopal also felt, as I felt, is this is not a patient for a SSA alone. If I give SSA alone, we both, I think all of them also agree that this patient may have a very short living response, or this patient will likely progress within 3 to 6 months. So therefore, we feel that an SSA alone is not sufficient in this patient. We need some escalation along with SSA. Yes, we all want to give, but along with that, we need to give some escalation. That's what we feel. The escalation in the form of PRRT is evidence based on a study called Netter 2 study that said that in the grade 2 sort of higher, like above KIC, more than 10, grade 2, I think I think that was an inclusion. So there, if you give PRRT along with SSA, there is a better PFS. So that's the escalation which should be important. So this is some grade 2 NET where a lutetium combining in comparison with octreotide, hazard ratio is 0.3, and for grade 3, the hazard ratio is 0.2. So this is escalation that we all would love to do, and a SSA alone is probably not sufficient. This is the response rate on combining uh, lutetium therapy along with octreotide. The comparator was high dose octreotide. So I think first learning for all of us is SSA alone in a high disease burden or a grade 2 uh, is not sufficient. SSA is not sufficient. We need to use a escalation like a combination, just like nectar 2 study. Okay, now, so this,
sir, can I add on one point, sir?
please.
Like as you said, sir, everything. So one point what I do in my practice, like if any patient of NAT without any functional component. So not only the serum biomarkers, if patient is not symptomatic for the functional disease like diarrhea or acidity or this any of the hypoglycemia, all those things. So without any functional symptoms, directly SSA I don't start with. This patient had dyspepsia, acidity. Probably on endoscopy there would be some gastric ulcers and all. So based on that, SSA is okay. But if any patient is not having any functional symptoms, straight away I can go ahead with other systemic therapy without even SSA. But patient with SSA, yes, definitely I will add SSA along with some debulking treatments.
Right.
So,
So you need to you need something beyond the SSA. So that's the point that we are making. Fair.
yes, sir.
So and SSA is mainly for secretory functional nets. That's what you're mentioning, no?
Yes, sir.
Right. Okay. So now this patient went on to take sandostatin, that is LAR 17.3, and then Dotanox showed increase in some of the, in a matter of 4 months, there is increase in some of the peritoneal deposits. So now, so this patient is clearly not responding to a single agent LAR, octreotide LAR. So, so this patient went on to take octreotide plus everolimus, and a repeat biopsy from momental nodule is grade 2. So continued on the same. I mean, yeah. So now let me request Avinash, sir. So Dr. Avinash, re-biopsy, So which are the scenarios where you would consider a re-biopsy, and how do you decide which site you want to re-biopsy, and how will it change your practice?
So if the expected PFS is somewhat lesser than what is generally accepted standard, that would be one indication. And the disease rate of progression is something which is very bothersome. The disease has rapidly increasing despite of using one of the best treatment available. Then we should go for a biopsy to see whether it is progression into a higher grade tumor. And for biopsy, we have either a DOTA-TOC avid lesion or DOTA-TOC non-avid lesion. So if the chromoganin is higher and DOTA-TOC non-avid region should be, I think, a better option for taking a biopsy to find out whether it has converted into a grade 3 NET or because if it's a grade 3 NET, treatment options would be quite different compared to if it remains a grade 2 NET. And in this case scenario, I think standostatin PRRT should be added over standostatin because there were quite a few lesions who were DOTA-NOC avid and there was a high chances of responding. And even now, the chromoganin A is coming up from 66 to 307. So this patient is progressing both, I think, at the DOTA-NOC avid lesion as well as the non-avid lesions. Hence, in this category, it's better to have gotten a biopsy to make sure that things have been same or stable or it has progressed into transformed into something else. So here they have done a repeat biopsy, which shows a relatively similar picture with KS7 of 16%. And here the treatment they have continued same, but I would have preferred standostatin and PRRT on this case, in this patient.
Right. So when it's not fitting into the natural picture, rapidly increasing from the most FDG avid area, you want to do a re-biopsy. And in this patient on octreotide, if there is progression, you can in fact continue octreotide LAR and add PRRT. This is the evidence based on the NET-1 study that established PRRT as a standard of care. So PRRT can come in this patient and biopsy from the most FDG avid lesion to look for the grade. So some response and continued on obtruted everolimus. Now, April non-DOTA avid liver lesions have increased. Chromogranin is increased. Whole body PET CT scan, PET study, all the lesions which were showing no significant DOTA uptake or FDG avid. That means from a DOTA avid, it has become a FDG avid, and a rebiopsy has been done. It is 23% grade 3, right? So this is how the progression has happened, right? So one thing we need to see is all grade 3 neuroendocrine tumors are not the same. The Nordic study retrospective analysis suggested that those who have a Ki67 of less than 55% did not respond well to chemo, like platinum etoposide, whereas those above 55% did respond well to chemo. So a grade 3 is not a reflex chemo. Okay. So that's the caution that we need to think. A grade 3 with a low Ki, something like 23%, probably that's the area where you would look for a TKI, and chemo is mainly for Ki above 55%. So let me ask Dr. Rajiv, your thoughts on how do you look into that heterogeneous subset of a grade 3 NET, Ki above 20%, grade 3 versus let's say a high grade neuroendocrine like 60-70%. So do you look them differently in practice?
Well, sir, with high grade, I think if you are you talking about the NECs, neuroendocrine carcinomas? I mean, are you considering them as a grade 4? I believe that if it becomes a different beast, if it becomes an NEC where it behaves like a small cell carcinoma, and there we can give definitely the only option we have is the platinum chemotherapy. But I think we have data of the grade 3 NETs where capecitabine and temozolomide can work well. And in this situation where we are seeing that the tumor there is a biological transformation where it has gone from 2 to 3, and also they have become a DOTA non-avid to FDG avid. So that probably indicates that the grade is also increasing. So here I think I would use capecitabine with temozolomide if it is still into grade 3, and if becomes high grade or NECs, then of course we have to give platinum based chemotherapy.
Right. So I think that's the important point as Dr. Rajiv made. So all grade 3 are not the same. Okay. Ki above 55 are or the high grade carcinomas, or even a NET grade 3 above 55 is platinum chemo. Less than that, probably a TKI like a Cabo or a Sutent, right? I mean, sunitinib is mainly for pancreatic, whereas for non-pancreatic, you have axitinib, you have cabozantinib as options. Anyway, this patient took Captem, again didn't respond, and then on sunitinib, again progression. So these are some data like chemo doesn't work well in a low Ki, like less than 55, the response rate is so less. So we have to be little cautious before we give chemo to these patients. So this patient took etopo-carbo progression, liver decompensation, and we lost the patient. So Dr. Selvaraju, if I can ask you, how has been your experience of chemotherapy in a grade 3 NET? It's not impressive, like 20% response rate. There a TKI probably would have done. So what are your thoughts?
Yeah. So as you rightly pointed out about the Ka67, 55%, and also the differentiation. If it have been poorly differentiated, again it might help in platinum using in this poorly differentiated grade 3 with slightly higher Ka67, they might benefit with 8% carboplatin. So,
Right.
so the
Right. Right. Correct. So just a grade 3 label is not enough to give a chemo. There probably a TK. I think Cabo has shown a benefit both in pancreatic and extra pancreatic neuroendocrine tumor. So that's where you can. Right. I think we discussed very important points. We covered all important points. Number one is we should have early integration of PRRT in the front line if it's grade 2 or grade 3, right? Early integration of PR netter 2, and then post SSA progression, rather than adding everolimus, you can have PRRT. That's better. And then number 3 is biopsying from the most FTG avid lesion to look for the grade change. And number 4, all grade 3 are not the same. Ki67 of 55% is the cutoff. Less than that, continue TKI is mainly probably. If it's more than 55, then go to chemo, especially platinum-based chemo. So with this, I would thank all the panelists for their very active thoughts and thanks for this wonderful opportunity.
Thank you, sir.
Dr. Chandrakant sir, for joining with us for this osmosis during your valuable and busy schedule time, sir. We will carry on this such osmosis in carry forward. So I will hand over to Anjana for welcoming the next sessions, panel members. Thank you.
Okay. Thank you so much, Saurav. So, our next case presentation would be on evolving landscape of BRCA mutated ovarian cancer. And the moderator for this session would be Dr. Amrendra Amar, consultant medical oncologist, Medanta Patna. So, would you like to introduce the panelist or I do it?
Yeah, so please do it on my behalf.
Okay. Next, please. Okay, so the panelists for the second case presentation are Dr. Pradeep Mondal sir, consultant medical oncologist, Manipal, Kolkata; Dr. Amitabh Upadhyay sir, consultant medical oncologist, TMH Jamshedpur; Dr. Umesh Shankar Kutum, consultant radiation oncologist, ACCF, Dilburg; then Dr. Duncan Khanikar, consultant medical oncologist, SCI Guwahati. So with this, I would like to hand over the session to Dr. Amrinder sir. Over to you, sir.
Yeah, thank you. I'll share my slides at my end only.
Okay.
Yeah. I hope that is visible to all.
Yes, sir.
Yes, sir.
It is visible.
Yeah, so welcome all panelists and thanks to Samar. Welcome Dr. Pradeep, Dr. Amitabh, Dr. Uma Shankar and Dr. Duncan. Hope everyone is available. Yeah, so I'll be talking of the treatment options in BRCA mutated ovarian cancers. Oft repeated topic. We have heard of all these things quite often in last 3-4 years. So I don't think there would be much to discuss in this. Still, for our knowledge, for updation of our knowledge and refreshing our knowledge, we will discuss this. So we will discuss about ovarian cancer management, long-term safety data of PARP inhibitors, chronic toxicities and their management, and we will discuss some of our own experiences and the strategies as to how we manage the patient adherence as well as we manage the toxicities. So ovarian cancer, we know it is one of the lethal malignancies. Most of these cancers, even though treated well, even though responding well, they would recur in a great subset of patients. Roughly around 60% or 70% of these patients would recur within 3 years. And the higher the stage, the higher the likelihood of recurrence. genetic drivers that include, and we know that high-grade serous carcinoma is the majority of all these epithelial ovarian cancers. And in that subset, T53 and BRCA1 and 2 mutations are quite common. So going to a case presentation, this is a 62-year-old female bank manager with 2 children and with no history of cancer in the family. She was a patient of diabetes and reached menopause 6 years ago at 54 years. So past 6 months she was having abdominal pain, early satiety and bloating sensation. There was no history of bleeding, PV bleeding or any other bleeding, changes in bowel habits or weight loss. Performance status was 1 and vital signs were stable. So clinical examination showed pallor and mild pedal edema, and there was abdominal distension and flank dullness was there. So at this point, if such kind of a patient present to you, so I hope Dr. Pradeep is available.
Yeah,
Dr.
yeah,
Pradeep?
yes,
Yes, sir.
yeah.
All
Hi,
your
Dr.
panels are
Pradeep.
available today.
Yeah. So hi, Dr. Pradeep. How are you?
Fine, sir, fine.
Yeah. Yeah. So, a 62-year-old female, bloating sensation, early satiety. Obviously, you will think of some intra-abdominal malignancy being female, most likely some gynecological malignancy. How do you generally work up these patients, Dr. Pradeep?
Yeah. So definitely that I like to na like to examine clinically. Of course, that will take the history of the patient, whether any bleeding PB, bleeding PR, all this kind of thing, melina, all this kind. And then definitely I would like to uh,
Hello.
hello, yeah.
Yeah.
Then I'll do the biomarker testing like that CA125, CEA, and imaging. Of course, that I like to do one CT there because most of the this kind of patients will come with some ultrasonography reports. At least they will come with, and we'll do some imaging, CT thorax, abdomen, pelvis, and if that CA125 is very high and patient is CA is low and there is a very that's unilateral that adnexal mass, then I'll usually can avoid doing that GI scopies. Otherwise, if there is no, confusion between that, it is probably GI versus no, primary peritoneal carcinoma or ovary, then I will do that no, GI scopies, upper GI endoscopy or colonoscopy.
Yeah. So ruling out Krukenberg in case of bilateral adnexal mass, right?
Yeah, yes.
Yeah. So fair enough. Yes. Perhaps we all would be agree with what Dr. Pradeep is following. We would do the same thing in our practice also. So, routine hematological and biochemical examinations were done. Tumor markers CA125 was very high, CEA was low. Cytological examination of ascitic fluid was positive for adenocarcinoma. At this point, I would like to go to Dr. Amitabh. So, Dr. Amitabh, good evening. How are you? Dr.
Yeah, good
Amitabh?
and thank you. Fine, thank you. Thank you.
Yeah. So, Dr. Amitabh, in our setup, see, most of these patients would be having some ascitic tapping at their primary center, even if it is not a cancer, a cancer care center or an oncology center. So, if they come to you and it is a cytology. So, based on this CA125 and cytology of malignant cells and imaging, would you still go for some kind of biopsy, or would it be suffice to go ahead for further treatment?
Yeah, so if you go by literature, then if whenever there is cytology positive and CA125 is to CA ratio more than 20, So that suffices your requirement, I mean, the prerequisite for starting chemotherapies. In this case, it's 920 divided to 2.2, so more than 20.
Right.
So theoretically, we can start new chemotherapy with platinum doublet plus minus bevacizumab, since the CITC is also there. And if at all, I mean, we can also always ask for the preparation of a cell block from our pathologist, because if a cell block is there, then we have the option of doing this HRD testing upfront. Otherwise, in some of the cases when we don't have the biopsy, then probably you need to wait for the interval cytoreduction surgery, and then we ask for the HRD testing on the residual tissue.
Yeah, very right, very right. Yeah. So if we are going for some kind of genetic testing like HRD positivity or germline BRCA, I mean germline BRCA can be done at any time. But yes, if HRD has to be done, it has to be done on the biopsy block. So yes, if cytology is positive, we can go ahead, but then we can't go for genetic testing just based on cytology. So going forward, a scan was done. It was a PET CT scan. Dr. Uma Shankar, hi, good evening, Dr. Uma Shankar.
Good evening, sir.
So I realize that you are working at ACCF.
Yes, sir.
Yes, so I'm not sure whether PET CT scan is available at every center. I'm just unaware. So is PET CT scan available at every ACCF center?
It's available in Guwahati, Dibrugarh, Silchar, and Barpeta, 4 centers out of the 17 centers.
And you are working at which center?
Dibrugarh.
Okay. So just for a discussion, academic discussion, if there is no PET CT scan, would you still ask the patient to go to a center where PET CT scan is available, or you would just commence your treatment after CECT chest and abdomen?
Yes, I'm comfortable with the CCT tape. Based on the CCT, we usually start. We usually don't refer cases for PET scan, especially in CA ovary.
Right. Yeah. So most of the gynecological malignancies, perhaps PET CT scan. Yes, some of the lung metastasis to lung, where you are not sure if that nodule is malignant or not based on CT scan. Perhaps there it can help PET CT scan, but almost majority of cases CCT chest and abdomen would be good enough. So anyway, in this patient, bilateral adnexal soft tissue, hypermetabolic abdominopelvic peritoneal deposits and moderate ascites was there. So it can be seen here. The disease burden is very high in the pelvis, and these are obviously these are illuminating on FDG scan also. So now omental biopsy was suggestive of high-grade serous papillary adenocarcinoma with positive CK7 and WT1 and negative CK20, consistent with ovarian primary tumor. 2D echocardiogram was done as a part of investigations prior to treatment. So final diagnosis was stage 3C, high-grade serous ovarian carcinoma. So I would then go to Dr. Duncan. Hi, Dr. Duncan. Good evening.
Hi, sir. Good evening, sir.
Yeah, Dr. Duncan. So this is 3C high-grade serous ovarian carcinoma. Just for our knowledge, sake of refreshing our knowledge, had it been a patient with pleural effusion as well, would you have done some other tests, or you would have gone ahead with this, the subset of tests that we have done?
Probably for medical legal issues, probably I would have considered pleural cytology as well. But probably in this setting of a patient who has such extensive abdominal disease, developing a pleural effusion probably is no big deal, and we will consider that pleural fluid to be malignant unless proven otherwise.
So let's discuss the case further, then we will discuss some more questions. So I'm not going into type 1 and type 2. Management, we know what we have to do. NSCT, bevacizumab has to be added or not. So these are the trials. So if we have given NACT, then what to do after NACT? So these are some of the trials, some of the diagrams, some of the protocols that we have to use in the treatment setting. So, Dr. Duncan, once again to you, do you test BRCA or HRD upfront, or do you do it afterwards after doing neoadjuvant chemotherapy or surgery?
Uh, Definitely the counseling starts at day one itself. We definitely counsel the patient for genetic counseling, but probably our treatment won't wait for the HRD testing or even the germline or somatic BRCA testing, because it doesn't really impact the initial perioperative treatment, if that is the
Right,
plan
right.
in a
Yeah.
multidisciplinary center. But definitely our counseling starts on day one itself, and we counsel them that you need to do this test because this is actually important for you for considering future PARP inhibitor if HRD or BRCA comes up positive.
Yeah, Dr. Uma Shankar. So in your setup, do you go for primary debulking surgery, or do you go for NACT in every case, at least in advanced, like stage 3C or some of the stage 4 cases, or even in stage 2 also, would you go for NACT or primary debulking surgery?
Uh, Actually, in this kind of cases, we usually bring this case to the tumor board. In the tumor board, we discuss extensively. Usually, we prefer go for NACT upfront, followed by debulking surgery. And
Okay,
most of the surgeons also prefer that.
okay. So then going to Dr. Amitabh. Dr. Amitabh, in our setup, it's difficult to counsel patients for chemotherapy. Yes, of course, chemotherapy is difficult. Some of the patients, they are not really willing for any type of chemotherapy, even though we know that the chemotherapy works well in ovarian malignancy. But how difficult is it to use bevacizumab in these kind of patients? Your setup at Tata Jamshedpur, how is it? How difficult is it to convince patients for bevacizumab and other targeted therapies?
Yeah, understood. So I will say not much because first of all, bevacizumab, the cost has reduced drastically with the so many generics being available, biosimilars being available, and also the bevacizumab is covered by our corporate this thing, and also bevacizumab is also available under Ayushman and the whatever our state government is providing. So counseling for bevacizumab is not very. Some patients they do have their concern regarding the increased risk of thrombosis and cardiac cerebrovascular accidents and all, and bleeding. But usually 90% of the patients they do agree for bevacizumab.
Yeah. So and then when do you stop bevacizumab, or when do you keep giving bevacizumab even before surgery in the third cycle, or do you stop in the second cycle and then move forward without bevacizumab in the third cycle?
Yeah, exactly. So this is the standard protocol we discuss in our tumor board, and we usually give 3 to 4 cycles. So if our plan is 4 cycles, so that we assess clinically how well beautifully the patient responded to first and second cycle. For the initial 2 cycle, definitely yes, it's platinum doublet plus bevacizumab, and if the patient responded well, then probably we'll give the third cycle with only chemotherapy. If the patient is still responding, still some mild ascites is there, then probably we'll go for the 4 cycles, and third cycle also will give with paclitaxel and bevacizumab, and fourth cycle I'll give only platinum doublet. So one thing is common that bevacizumab has to be stopped in the penultimate chemotherapy doses.
Yeah, yeah. So, Dr. Pradeep, before giving bevacizumab, which set of tests uh, uh, do you ask the patient to undergo?
তারপরে নিচের ম্যাডামটা ফোন করছিল না তাই আপনাকে ফোন
What? Before starting bevacizumab, which
Yeah, yeah.
set of tests do you prescribe the patients to undergo?
Okay. So at least I will take the history that person is having any recent cardiac failure history, any thrombotic recent thrombosis, any recent surgery history. All these things history I will take, and at least I will do one 2D echocardiography and mm, baseline urine test, we can do that any proteinuria is there or not, but mostly do at least an echocardiography for doing and check all that contraindication of bevacizumab.
Yeah. Yeah, so fair enough. There could be sometimes there could be signs of subacute intestinal obstructions also, where we have to be very cautious. Rather, we won't be able to give bevacizumab upfront, and after chemotherapy, perhaps we will add bevacizumab. So yes, most of us would agree that in NACT we are adding bevacizumab quite often than not, and yes, in cases of ascites and all, it works well in addition to chemotherapy. So one question more, Dr. Pradeep. So is it
Yeah, yeah.
paclitaxel or are you adding some other like albumin bound or pacli aqualip kind of thing, or is it just paclitaxel?
Mostly paclitaxel. Mostly paclitaxel. If contraindication for paclitaxel, if patient is severely diabetic, I want to avoid steroids kind of thing, then only. Otherwise, I use in NACT paclitaxel,
Okay,
mostly
great.
conventional paclitaxel.
Yeah. So yes, most of us would give 3 to 4 cycles of chemotherapy and then would assess the patients for surgery. And if she has responded very well, obviously we will go for interval cytoreduction plus minus hyper. And if bevacizumab was not given, perhaps we would add bevacizumab depending on how the surgery was done, what was the residual, if there was any residue or not, or bevacizumab, if it was given upfront, probably we will continue. And based on this, here we will add PARP inhibitors based on the reports of BRCA testing or HRD testing. So that we all will agree. So this is the NCCN guidelines where the same has been mentioned. I'm not going into detail about all these things. So after a multidisciplinary team discussion, she was initiated. Now, this is quite interesting. I would go to Dr. Uma Shankar. Dr. Uma Shankar, how frequently you give weekly paclitaxel and carboplatin in your patients, and what is your indication to start weekly paclitaxel and carboplatin?
Uh, Actually, I typically use 3 weekly pegnicarbo and plus minus bevacizumab. Weekly, I don't use usually because most of our patients are from Ayushman background, and in Ayushman, weekly is not available, I guess, in ovary. So we use 3 weekly only.
Okay, so Dr. Amitabh, which subset of patients you would like to give weekly chemotherapy?
So preferably in the patient with a poor performance status or 65 to 70 years plus with comorbidities, then in which monitoring the adverse effect is my priority, then in those subset I'll prefer weekly regime.
Yeah, so I think that was MITO 7 trial which had compared weekly with 3 weekly, and I think there was no difference in the response rates, but it was more tolerable in those type of patients, those subset of patients. So, fairly, these patients were also given 3 months of treatment with neoadjuvant chemotherapy, and bevacizumab being, as rightly said by Dr. Amitabh, so in the penultimate cycle, bevacizumab was omitted. Now you can see that CA 125 has gone down to 52. It was like 900, and response evaluation CT scan revealed resolution of ascites and significant reduction in omental and peritoneal disease. Adnexal mass also shrank considerably. Now here comes the role of surgeon, and surgeon did a good job doing interval cytoreductive surgery, but resulted in R1 resection because of the involvement of root of the mesentery. We know involvement of root of the mesentery is one of the contraindications of upfront debulking surgery. And here, even after treatment, it did not result in clearance of the deposits in root of the mesentery. So there is a residual disease. And that procedure involved the standard one like abdominal hysterectomy, bilateral salpingophorectomy, omentectomy, and post-operative histopathology revealed residual viable high-grade serous ovarian carcinoma. Now, it is a residual disease. The tumor had responded very well. Ascites had cleared. The adnexal mass had also shrunk. But now this is a residual disease. So I'm going to Dr. Duncan. At this point, what comes to your mind? What should you do? Should you change to some other treatment? Should you give something else? Should you add PARP inhibitors because of residual disease? Or what other thing comes to your mind?
Well, I usually don't change my practice. Definitely, as per standard guidelines, you need to have at least 3 more cycles of adjuvant systemic therapy. So I'll go ahead with that. And definitely now the importance of HRD testing or germline BRCA comes into play. And if BRCA is mutant or HRD positive, definitely I will encourage the patient to go ahead with PARP inhibitor use as maintenance therapy. Or if bevacizumab was utilized, then I'll continue it with PARP inhibitor.
Great. So one more question comes to my mind. So because let's say we have not done an upfront HRD or BRCA testing in this patient. Now at this juncture, we have some residual disease and we have histopathology and we have tumor tissue. So in your setup, practically, what do you prefer, doing germline BRCA or do you go for HRD?
I would always prefer HRD because it covers the entirety of the homologous recombinant repair. And actually, it's a reflex testing. If suppose there is a slight indication of a germline mutation, then definitely we have to go ahead with germline testing as well, because that is also important for counseling of other family members. So I'll definitely prefer HRD testing first.
Yeah, but the cost is an issue,
Yeah,
HRD.
cost is an issue. Definitely cost is an issue. So that actually puts significant brake on our thought process at times.
Okay, so if let me ask you in another manner. So if we think that germline BRCA should be done, and HRD perhaps affordability is not there, and we are thinking of germline BRCA positivity. So does that mean if there is germline BRCA positivity, it would not be there in the tumor tissue?
No, if germline BRCA is there, it's present in all the cells, not only the
Right.
normal tumor cells, also in the normal cells. So that
Yeah.
actually simplifies the matter a lot. If germline BRCA is mutant, we are done actually. We have a very good benefit. The patient will get a very good benefit of PARP inhibitor. But
Because
as per the solar trial, they also retrospectively assessed somatic BRCA as well. And even there, they did find the same PFS, DFS, as well as the OS benefit that they have shown in the 7-year follow-up. So
okay.
yes, if HRD is not possible, I will definitely go ahead with germline, as well as I'll definitely will counsel the patient.
Because Dr. Uma Shankar is working at a center where Ayushman is there. So perhaps there it would be difficult to do HRD testing. Dr. Uma Shankar, is it possible to do HRD testing at your center? Dr. Uma Shankar, please.
Yes. Yes, it's very difficult to do HRD testing at our center because most of the patient can't afford it. But we have some grants also. Especially in some in few cases we might do HRD testing and actually in selective cases we only do the germline testing only. If
Yeah,
patient is
so I
affording,
think
then we go for the HRD testing.
I think germline BRCA would be more cost effective in your setting or perhaps in any setting in India, perhaps most of the settings in India, isn't it?
Yes.
Yeah. So now going forward, so Dr. Amitabh, we have already discussed. I discussed with Dr. Duncan. So we would continue with the same regimen with addition of bevacizumab, or would you like changing regimen? I think no.
No, I would like to continue with the same regime. I will complete 6 to 8 cycles of chemotherapy along with bevacizumab. And
Yeah.
then depending upon the BRCA or HRT, further maintenance therapy prefer to add.
Okay. So bevacizumab, would you like to continue after 6 to 8 cycles, or would you stop bevacizumab and then continue with olaparib or PARP inhibitors or any other PARP inhibitor? Dr. Amitabh? Hello? Dr. Amitabh, am I audible? No.
Dr. Amitav, you are in mute,
You're
sir.
audible, sir.
Yeah, I lost your voice. I didn't hear the question. Can you please repeat? There was
Okay,
some
so if
connectivity issue.
if there is BRCA positivity or HRD positivity, so definitely you would like to add PARP inhibitors, but would you like to continue with bevacizumab to 15 or 18 cycles, or would you just stop bevacizumab after 6 to 8 cycles?
So again, there was connectivity issue, but I believe I can guess the question that you're asking about bevacizumab plus. So I would like to continue bevacizumab and I also like to add olaparib because out of all the three options, the
Yeah,
Paola-1 study is the
Paula,
strongest
right.
study. It's BRCA1 positive subset bevacizumab plus olaparib for 2 years. So that I will
Yeah.
continue.
So that is the evidence Paula study. Yes, very right. So this is weekly versus every 3 weekly paclitaxel and carbopaclitaxel. We discussed this. So icon 8B. So there was this again. This was weekly and 3 weekly. Not going into detail. Uh, Progression-free survival. Now this is on icon 8. The progression-free survival and overall survival with subsequent PARP inhibitor use, and we can see that there is additional to 28 progression-free, 28 PFS event and difference of 4.9 months in median PFS in favor of arm B3. And here arm B3 is this carboplatin 3 weekly, paclitaxel weekly, and bevacizumab every 3 weeks. So if we continue with bevacizumab weekly paclitaxel and carboplatin every 3 weeks, and then continuing the bevacizumab maintenance, this is the arm B3 in icon 8B trial. So we see there is a little benefit in the PFS data. Median PFS increases from 16.5 months to 21.4 months. And remember, this is weekly paclitaxel, whereas it is 3 weekly paclitaxel. So icon B8 shows that weekly
So,
paclitaxel could be better.
so sorry to interrupt you, but we are running out of time, so it would be better if you can close.
Yeah, sure.
Thank you.
So moving forward, overall survival also gets better. So now bevacizumab and dose-dense paclitaxel before interval cytoreduction help more patients to achieve optimal cytoreduction, thus leading to better DFS and OS. And dose-dense paclitaxel along with Bev in neoadjuvant setting after confirming it is non-BRCA HRD negative. So going forward, so these are the mutations. HRR and HRD. Yes, HR we know we test HRR, we test genomic scars also. HRD is like all those homologous recombination deficiency and maintenance we have discussed already. So treatment overview we have already discussed. These are all the trials wherein chemotherapy and then PARP inhibitors were added based on Solo 1, Paula 1, etc. And then these are the PARP inhibitors, olaparib, then came niraparib and rucaparib in June 22. This is the timeline of development of PARP inhibitors. It is interesting to note that PARP inhibitors were discovered in 1966, but these particular molecules those were discovered at least after 50 years of discovery of PARP inhibitors. So it takes a long time from in translational activities. Solo one is obviously PARP inhibitor in BRCA positive serous ovarian cancers, and it led to 5-year follow-ups shows that PFS, obviously median PFS increases manyfold in addition in comparison to placebo. And here you can say that it was median treatment duration was 2 years with olaparib and placebo 13.9 months, but median PFS was 4 times higher in olaparib arm. So obviously these are the side effects we see: nausea, vomiting, anemia, diarrhea. More commonly we see in elderly patients, but these are more tolerable in young patients. Obviously, grade 3 and grade 4 toxicity, grade 2 and grade 3, we decrease the dose of the olaparib. Solo 7 years follow-up showed that there was 45% improvement in the survival with a HR of 0.55. So, Paula, we have discussed. Paula was chemo plus chemo followed with bevacizumab followed by PARP inhibitors. So I'm not going into this. So the dose interruption is needed in PARP inhibitors, sometimes very difficult to manage, particularly in old age patients. And some people start with higher doses, go to lower doses. Some doctors start with lower doses and then go to higher doses. So this patient was continued on bevacizumab maintenance, developed anemia. Anemia has to be, managed. We check all the nutritional parameters, iron levels, vitamin B12, folate, and if that is manageable, we do that. If that is not due to this nutritional deficiency, we have to reduce the dose of olaparib. Nausea and vomiting is also common. So that brings my presentation. Thank you. I have taken 45 minutes. Thanks all my panelists. It was nice discussing with you all, and thanks to Samarth. Over to the organizers.
Thank you so much, sir. So, for a very elaborate presentation and all the panelists for such a great discussion. So, now let us move on to the next case presentation. Okay, so the next case presentation is on real world case presentation on metastatic CSPC. The moderator for this session would be Dr. Prashant Paridhasa. He is a consultant medical oncologist, HCG, Cuttack. And the panelist for this presentation would be, sir, would you like to introduce or should I do it?
Yes, you can introduce.
Okay. So the panelist for this case presentation would be Dr. Aditya Mishra, sir. He is a consultant medical oncologist, Apollo Hospital, Bhubaneswar. Dr. Hafizul Islam Pathan, sir. He is a consultant radiation. Okay. One second.
Should I share again?
Khushi. Okay. Dr. Hafizul Islam Pathan, sir. He is a consultant radiation oncologist, ACCF, Darang. Dr. Tarun Jindal, sir. Consultant surgical oncologist, Kolkata. Dr. Nishant Loya, sir. Siliguri. And Dr. Apko Porva Haldar, sir. From Kokhajar. Over to you, Dr. Prashant, sir.
Thank you, madam. Good evening, everyone.
Prashant sir, could you please put the screen on slideshow mode?
I'm trying to do that only.
Okay, no problem, sir. Take your time.
Sir, below there is a square window. On that you have to click. Yeah. Okay.
Now it is visible.
Yes, sir.
And in slide mode.
Yes, sir. Yes, sir.
Okay. So I hope all my panelists are present. So we directly start the case.
Yes, sir. Yes, sir. All your panelists are present, sir.
Okay, thank you, ma'am. So let us have a discussion about prostate cancer, especially castration-sensitive, metastatic hormone-sensitive prostate cancer. So this definition-wise, castration-sensitive means either patient not treated with any form of androgen deprivation therapy or not on androgen deprivation therapy at the time of progression of disease. So directly we'll go to the case. This is a 55-year male. He had a comorbidity of diabetic, hypertensive, CAD, had angioplasty 8 years back. Presenting complaints, painful micturition, PSA was 95, and PSMA PET shows both lobes of prostate, lymph nodes, T3, L3 vertebra body, and left acetabulum are the uptake on PSMA PET CT. So these are the disease site, and biopsy done, adenocarcinoma gleason 9, gleason score 9, and PDL1 on biomarker testing, MSI stable, PDL1 35. So, Dr. Aditya, you are there?
Yes, sir. Good evening, sir. I'm here.
Yes. So, what is your diagnosis and what will be your initial treatment for this patient?
Yes, sir. So our diagnosis here would be de novo metastatic castration-sensitive prostate cancer. As per Chattered, this doesn't qualify as a high volume disease, so it's a low volume disease. And as per Latitude, it is a high risk disease. So de novo metastatic, it's a castration-sensitive prostate cancer, low volume, high risk.
Okay. So, rightly said, Dr. Haldar, Arkoprova Haldar, you want to differ here?
Sir, we can like.
So this is a metastatic hormone sensitive or de novo metastatic prostate cancer. So what will be your initial treatment?
Initial treatment, sir. I feel it is. We can call it high volume because I think one lesion is outside. I think axial skeleton. So it is just like so just high volume. So and other criteria is high risk like high glycine and high PSA. So even though patient has comorbidities, but if age is less and if the disease, if the medical issues are well controlled, I would still offer him a triplet therapy. So ADT along with either abiraterone or a androgen receptor blocker, or and if there is no diabetic neuropathy and all, I can even I can add docetaxel. Regarding
So you want to
the
go with the doublet or triplet here?
yes, sir.
You want to go with the doublet therapy or a triplet?
I would go for triplet, sir. The patient is relatively younger patient. Assuming his cardiac, other comorbidities are well in control.
So
And
he had a cardiac abnormality, diabetic, hypertensive, CAD. So he had lot of comorbidity and had angioplasty. So we have to rethink to start a triplet here. So you still want to go to with triplet here?
If the current cardiac status like ejection fraction and all is okay, and I think as such docetaxel that is don't direct cardiac contraindication. Main I would look for is any diabetic neuropathy. Regarding the, I would rather change the ADT. I would not give a GnRH analog. I would give a GnRH antagonist like relugolix or degarelix. That is much more cardiac.
We'll go to ADT lateral. We'll go to ADT lateral. Now the initial treatment. Okay. So, Dr. Nishant, you are there?
Hello. Yes, sir. Sir, just yeah. Good evening, sir.
Yes. So regarding RT here, so
Yeah.
you have seen the disease
Yeah,
side.
before RT, I need to reclassify again whether I'm dealing with high volume or low volume. As rightly
Yes.
pointed out by one of the speakers that it was low volume. and other speaker pointed out is high volume. But there is a thin line of difference in high volume and low volume. If there are 4 bony mets with 1 mets outside the vertebral column, it is high volume. But there are 3 bony mets here. So the 3 bony mets itself, I would like to classify it as a low volume. If there would have been a 4 bony metastatic lesion and 1 would have been outside the vertebral column like the ribs out here, I would have classified it as a high volume. In high volume, the role of RT as such per se, as per latitude charted, it's not there. But in case of low volume, after doublet therapy, oblique triplet, whatever the patient takes, then I would go for maintenance, definitely RT, 55 grade 20 fractions, if it is a low volume disease.
So, Dr. Hafizul, you want to differ or your opinion is same? This is a low volume, you want to add EBRT?
Hello, sir. Good evening. Actually, sir, I want to. I feel like my opinion will be like coinciding with Dr. Nishant Lohia sir's opinion. Very correctly said. I think the classification of high volume and low volume, 4 bony mets and no visceral mets. So I think it's a low volume disease. And on top of that, we have, in this case, we have used a very sensitive test called PSMA PET-CT, which shows there are like only 3 bony mets. So I feel it's a low volume disease.
So regarding the volume of the disease, high volume or low volume, the most commonly used it is the chartered criteria. So there are few other criteria. You are telling regarding the chartered criteria only. Hello?
Yes, sir. Yes, sir. Yes, sir.
So that is the most commonly used criteria, less than 4. And for high volume, at least 1 should be outside the pelvic bones.
Yes,
so
sir.
this is,
Yes.
this is 3 bones and 1 lymph node is there. So we can consider as a low volume. So you can add RT. Okay, thank you. So this is the level 1 evidence for survival in different trials. The Stampede H, where docetaxel especially had benefit in the high volume subgroup, and the Stampede C, where docetaxel plus ADT benefit in high volume subgroup, latitude, arches, titan. These are the abiraterone, enzalutamide, apalatamide trial where the benefit was in both the risk group, whether it is low or high risk group, and these are the 2 triplet trials, the Arasens and PITCH trials, where in addition to ADT, docetaxel, either abiraterone or enzalutamide also improve survival further, but it should be in high risk or high volume disease, and patient should be fit enough with good end organ function and no comorbidity. In those subgroup, we can choose triplet also. So this is the the 3 landmark trials of 3 ARIs, abiraterone, enzalutamide, apalutamide, and you can see in all the 3 cases, the H are almost 0.6 similar, 0.66, 0.6. So, and this is the therapeutic landscape in metastatic hormone sensitive prostate cancer. Almost 15 years back, ADT alone was the standard of care. After that, ADT plus docetaxel, then different ARI combination. Now, triplet combination both in Arasen and this one shows OS advantage. And these are the 3 triplet, 2 triplet trial and designs. And you can see the piece on Arasen. Though the median OS not yet reached, but it is significant in both the trials, and in high volume, the curves are more widely separated in comparison to those. Now coming to few questions. ADT. So, Dr. Tarun, you are there?
Yeah.
So we are discussing regarding ADT. Being a surgeon, so you want to prefer the orchectomy, surgical ADT, surgical castration, or medical castration?
See, as far as the literature goes, I mean, the clinical efficacy goes, both are equivalent. So if you have medical or surgical, it does not matter. But if you are very considerate about the side effect profile, I mean, if you have a patient who has, say, known osteoporosis, or if he has a cardiac disorder, in those patients, I would still say orchidectomy will fare better than any kind of medical treatment, be it agonist, be it antagonist. There was a time in the NCCN guidelines also, so for bone health particularly, orchidectomy was proven to be better than any form of ADT. So I would say, I mean, I would give an option of both. Significantly comorbid patient, I would rather prefer orchidectomy over any form of ADT.
So we already know that the efficacy-wise, both the castration modes are almost similar efficacy. but it depends upon, it varies from person to person or patient to person, and there are several advantages and disadvantages of orchiectomy, or several advantages of medical castration. Dr. Haldar, which one you will prefer in this case?
So, as sir rightly said, that the orchiectomy has a slightly better cardiovascular risk profile. There was one, I think, CR database, but that has been challenged later on, and very fast attainment of castrate levels in with orchiectomy. But it was mostly, actually, we have discussed with the patient. So patients usually are not accepting of surgical procedure, so usually they prefer medical castration. So there is no right answer. So it is depends on the patient's preference and his clinical profile.
Yes.
So
So it can vary from patient to patient, but there are few advantages of ADT right now. Nowadays, we are most of the patients are preferring medical castration rather than surgical, but there are several advantages because the side effects profile, if you see, medical ADT or medical castration slightly higher risk of certain fat and osteoporosis. So that has been seen in few studies. And but castration, surgical castration, it is a single time, low cost procedure, convenient, and medical ADT needs lifetime repeat injections. And in medical ADT, but advantage of reversibility. Whereas body image feelings will be maintained in orchiectomy. So there are few advantages and disadvantages also, both in surgical and medical cases. Regarding intermittent or continuous ADT, Dr. Nishant, have you ever used intermittent ADT? In which scenario?
Intermittent ADT I haven't used because there was a trial where there was no benefit with intermittent. So in intermediate risk, generally, yes, I can go for intermediate ADT. Otherwise, in high risk, I don't think intermediate ADT, I have no idea. Only in intermediate risk where I can go for lower ADT. Otherwise, continuous ADT would be my take on in cases of metastatic hormone sensitive, and in cases of high volume, not high volume, basically non-metastatic locally advanced, I would go for 2 to 3 years of ADT.
Okay. So, Dr. Hafizul, your opinion regarding intermittent, continuous, and which scenario you will prefer?
Sir, I think I'll go with continuous ADT. Yes.
Yes. So for metastatic HSPC, usually continuous ADT is preferred, but in non-metastatic setting, especially biochemically relapse in non-metastatic HSPC, you can opt intermediate ADT. And nowadays, single mode ADT is not preferred in metastatic hormone sensitive prostate cancer. So most often we use continuous ADT. Doublet versus triplet we have already discussed.
Yes,
and regarding EBRT, we have already discussed role of anti-androgen. Dr. Aditya, have you ever used the anti-androgen? Previously, we are using in.
Yes, sir. So if we are using an agonist, so we need to, for initial 2 weeks to prevent the flare, we use anti-androgens, first generation biclotmide. But otherwise, if we are using an antagonist, there is no role of.
Yes, yes. So right now, only we have to use to prevent the flares. Otherwise, now we have more potent with second generation androgen receptor inhibitor. So right now, only we have to add for a few 1 or 2 weeks to prevent the LHRH agonist flare. In that scenario only we are using. So regarding the ADT, whether agonist or antagonist, Dr. Haldar, you are telling regarding the agonist or antagonist, which one will prefer in this type of patient?
In this particular patient has a cardiac comorbidity, so GnRH analog has increases cardiovascular risk. So I would prefer going for a antagonist, preferably releucolis, because in the HERO trial they clearly showed to be more cardiac safe compared to the regular GnRH analogs.
Yes. So rightly said, especially antagonists, they have less cardiac toxicity or cardiac comorbidities. So if patient have history of any cardiovascular disease, better to go with antagonist rather than agonist, because LH RH agonist more likely to have cardiovascular complications. And also, if patients with lots symptom, then we can go for antagonist for better or faster relief of these symptoms. So for this patient, Dr. Nishan, in your opinion, if additive plus severity is a good option,
Yes,
considering it is a low.
yes, I think it's a good option after as a maintenance or consolidation after the doublet oblique triplet therapy.
Yes, yes. So this has been seen in few trials also that improves survival, especially in low volume subgroup of patients. So the OS results, if ADT alone in the median survival was only 30 to 35 months. With doublet docetaxel, it was 40 to 45 months. With abiraterone, further improvement 50 to 50, and with the triplet, now it reaches up to 60 months, 61 months. So, but we have to select which subset of patient will have benefit from this triplet therapy, especially patients, young fit patients with high volume disease. We can offer them a triplet model. So regarding the endpoints, PFS or OS, which will be more important for you, Dr. Tarun? In this scenario, someone on hormone sensitive prostate cancer, you want to have longer duration of therapy to have a longer PFS to reach to the HRPC, or you will see the overall survival.
See, both are important. I mean, you cannot say one is better than the other. The overall survival is what we as oncologists are looking for. So anything which delays the progression from HSPC to an HRPC scenario will obviously also impact upon the overall survival. So I think both are important in their own scenarios.
Yes. So both are important, PFS and OS. Though OS, we sometimes we consider it is the definitive endpoint where we can opt our therapies. But PFS also very important, especially in these scenarios where a patient can survive, have longer PFS with this type of therapies. So this is the NCCN ASCO guidelines. The current ASCO guidelines recommend patient with low volume metastatic disease as per charted were candidate for chemotherapy, docetaxel plus ADT should not be offered for low volume disease. And on the other hand, ASTRO SEO guidelines state in patient with metastatic hormone cancer, they should offer ADT in combination either androgen pathway directed therapy, either one of the abiraterone plus apalutamide or enzalutamide. And a nice guideline also offer docetaxel chemotherapy to people with metastatic prostate cancer who do not have significant comorbidities. So these are the major advantages of early chemo versus saving it for later, longer survival, side effects are mild, and patient less debilitated from years. So as many as 10 infusions can be given if tolerated in docetaxel. Most patients are not resistant, so docetaxel can be repeated. And if resistant, also we have now cabazitaxel can be given. So in terms of second antiagent, which one you would choose, Dr. Aditya? So these are the second generation ARPIs. Which one will offer to your patients?
So this will primarily depend on the patient's comorbidities. The toxicity profile comes into picture, cardiovascular or metabolic, if we want a steroid-free treatment. So that will depend on mostly the comorbidities of the patient.
Yes. So if someone has hypertension or cardiovascular disease, diabetic, you want to avoid steroid because this abiraterone, we know it causes edema, electrolyte disturbance, so hypertension. So better to avoid abiraterone in those situations. For enzalutamide, hypertension, ischemic heart disease, they have history of fractures, falls, fatigue. So these are the common symptoms of endolutamides and neurocognitive effects. So patients having neurocognitive disease, better to avoid enzalutamide, apalutamide. And darolutamide, the newer one, slightly different mechanism of action and less monitoring is required, but it can cause seizure, hypertension, ischemic. So most of the time, these are the factors we see to start one of the second generation ARPIs. So regarding network meta-analysis, Dr. Haldar, you have seen the network meta-analysis regarding the ADT plus versus ADT plus these agents, arise or docetaxel. And what is your opinion regarding this network meta-analysis? So this is the network meta-analysis where you can see in comparison to ADT, adding any one of the ARIs, they have a benefit, and all the three ARIs are effective therapy for metastatic hormone-sensitive cancer, but apalutamide was best tolerated, but all three seem to be more effective than docetaxel. Then bone resorptive therapy. Dr. Nishant, because we are using ADT, which itself causes bone density loss, and these are the therapies, ARIs, they also aggravate the bone loss. So, is there any role of bone resorptive therapy in newly diagnosed HSPC?
Basically, in cases of metastatic hormone sensitive, I would like you to avoid initially the anti-bisphosphonates, because the STAMPED and CalGB has clearly shown that there is no change in overall survival. Yes, in castrate resistant bony metastasis and in cases of DEXA scan, if it is suggestive of osteoporosis or osteopenia, I might go for either 6 monthly zoledronic or denosumab 60 mg. Only in those two scenarios.
So it has been proved in metastatic CRPC, but in metastatic HSPC, you have to monitor. Especially we have a online score, track score. You can predict the risk. If it is more than 3% 10-year risk of pelvic or hip fracture, then better to have a DEXA scan. And if there is osteoporosis, you can add bisphenol or denosumab in these subgroup patients also. Any role of IO in this patient at this stage, Dr. Aditya?
Sorry, sir.
IO drugs.
No, sir. At this stage, no IO. We have evidence for IO in CRPC, especially the 190 segment, right?
Yes.
That is in heavily pretreated patient in CRPC setting. Yes.
In CRPC, especially, you have exhausted most of the therapies and the options are limited.
Yes.
In MSI high or TMB more than 10, in those subgroup, you can choose IO. And in these animals, the options are limited. Regarding PARP inhibitor, nowadays, the previous talk was regarding the ovarian cancer. It has been used as a maintenance therapy after response in ovarian cancer. So here, PARP inhibitors, role of PARP inhibitor, Dr. Haldar, in HSPC, metastatic HSPC.
Actually, I think PARP inhibitor, it is approved in BRCA mutation or HRR mutation. That is, we have to give, in that case, we have to give niraparib, abiraterone, and ADT. HRD, I'm not very aware. It is BRCA, approved in BRCA mutation, and I think HR, if any other non-BRCA HRR gene panel is positive.
Okay, so Aditya, Dr. Aditya, your opinion?
It is in CRPC setting, the profound trial and the return. It is in CRPC, mostly not in HSPC.
So recently, one trial in HSPC. Okay, so they have used niraparib plus abiraterone only in BRCA2 subgroup. It is a category 1 indication in addition to ADT. Previously, it was BRCA2, the profound TALAZO-2 trial. So all the talazoparib and olaparib was had efficacy in CRPC, but now in HSPC setting, metastatic HSPC setting, niraparib and abiraterone has been approved in metastatic HSPC also. So this is the trial, amplitude trial, phase 3 trial, and you can see. So niraparib plus abiraterone combination with prednisolone was approved for adult patients with relapsed or suspected BRCA2 mutant in metastatic hormone sensitive prostate cancer. So this is also in NCCN guideline. You can see the lower one, ADT with, especially in high volume disease, it is category 1, 2A recommendation. So now we can use in metastatic hormone sensitive prostate cancer also. BRCA2, why BRCA2? Because in most of the prostate cancer, BRCA2 mutation will be seen, and in rarely in BRCA1 will get the prostate cancer. This is the amplitude data. So our patient started on the ADT plus abiraterone, and few months after that, piece 1 data came in early 2022, and it was discussed with the patient. Docetaxel was added as a triplet. 6-cycle docetaxel was given and stopped, and the patient tolerated quite well. Are present on GnRH analog plus abiraterone, and patient is asymptomatic, working for 10 years, and he's a professional wildlife photographer, so he's doing well. So to conclude, in hormone sensitive prostate cancer, high and low volume needs to be defined. Select patients ADT plus BRT can be given in low volume subgroup, and almost all others ADT plus second antiandrogen standard of care. And high volume disease, fit patient triplet is also a option which can improve its survival. Thank you. Thank you for hearing. And now I'll hand over mic to the organizer.
Okay. Thank you so much, Prashant sir, for such a wonderful discussion and case presentation. So now I would request Saurav sir. Saurav, are you there?
Yeah, hi. Very good evening to all of you. On behalf of the Summit Oncology, I really thanks to all of our faculty members as well as the moderators, 3 moderators, with their expert discussions and the insights that we have received today. And very happy to say that we have again crossed the milestone of crossing 250 audience in the webinar today from the different corner of the India. Even some of the audience are from out of India, including all the junior, senior, and mid-junior doctors. So with that, I'd like to thanks again to all of you for your great contributions for this successful osmosis today we have conducted. And thanks to the organizer and thanks to the backend team, our my side viewers. Thank you.
Thank you so